All right. It's great to see everyone back here. My name's Anna Stearne. I'm a researcher at the National Drug Research Institute, but also a board member of NCCRED. And so I'm chairing this session, and we'll get straight into it. This session, we've got 7 presentations it's all research for intervention research for methamphetamine use disorder. So we've got some very diverse presentations. First up, we have Associate Professor Rebecca McKetin.
Thank you very much, everyone. I probably should have come up here earlier and worked out how to move this thing around. Anyways, so today we'll be looking at contingency management for methamphetamine dependence seed grant from NCCRED, and I'd like to start by acknowledging my many collaborators, many of whom are here today, but also our expert advisory group, who very generously gave up their time to meet with us and kind of give us a bit of a quick primer into what contingency management actually is. Hands up if you are familiar with contingency management. Okay, so for those of you who already know it, I'm sorry, but I felt that for the people who didn't, I should quickly tell you a bit about it. And before I do that though, I'll just explain why contingency management. For stimulant use, we did this review, it was published in the Lancet, and it was just a review of reviews. And you can see here that the effect size for CM, as I'm going to call it from now on, is it's a moderate effect size, and it's got stronger evidence than any of the other behavioural interventions for methamphetamine use. And as you know, we don't have an effective approved pharmacotherapy. So the big question is, well, if it works and it's there, why aren't we doing it? So I guess this project is really to look more about exploring, I'll just go back a bit actually, because we wanted to explore whether it's feasible and acceptable to do this in Australia and understand why it is we weren't doing it. And so as part of this, we had our expert working group to tell us a bit about CM and how it works, as I've just shown you. And then we're doing a scoping review, and then we're doing focus groups with stakeholders to understand their perspectives, and also in-depth interviews. And today we'll be looking at these 2, and then we're going to be finally doing an online survey of people who use methamphetamine. So just going back to here, that's why we're interested in doing it, because it seems to work, but we don't know much about it. So just to tell you what CM is, there are 2 classic models that everyone talks about when we talk about contingency management. The first is, very crudely put, giving people a monetary voucher for a drug-free urine. In this case, be a stimulant-free urine. So it's a bit of a carrot approach. But it gets a bit complicated. You see here, it starts off at a really piddly little amount for the first drug-free urine. But if someone can maintain abstinence and give consecutive drug-free urines, that amount goes up. If they give maybe 3 in a row, then they get a bonus. So there's an added incentive for staying off the meth for a few days at a time. And the idea behind this is you're kind of incentivizing continuous abstinence, and the idea that that should give a person an opportunity to instigate some kind of behavioural change that's more sustainable. However, there is a bit of a stick to it as well. If they don't turn up for their drug test, or it comes back positive for stimulants, it gets reset back to 0. So it's based on operant conditioning theory. It's what you do with your children. You give them stars for doing their homework, and you send them to the naughty room if they misbehave. So it's a very, very much a behavioural kind of paradigm. There's another version of this. It's the same principles. It was developed by Nancy Petrie in the USA, and instead of giving people a set amount of money, like a monetary voucher, you get to go in a prize draw. And this has been used in the VA system in the USA to treat stimulant use and other drug use. And it's become popular there because they can tailor the prizes. They actually give out prizes to people. So, or they can also give out monetary vouchers mixed in with those prizes. And it's a little bit cheaper because it is a lottery, so they've reduced the amount that it should cost. But that's kind of the only place it's been taken up, and it's had really limited implementation elsewhere, including in Australia. Now, there are a number of reasons for that, but one of them, as you can imagine, is it's quite cumbersome to implement. It takes a lot of oversight, a lot of resources, a lot of face-to-face contact. So people it's just kind of sat on the back burner for a long time. But in the last few years, there's been a reinvigoration of interest in this intervention. And I think it's on the back of digital technology. For example, one of our expert working group members has started doing contingency management to increase compliance with certain medications, opioid agonist therapies that are combined with other medications. And what she's done is, rather than have the clinic staff do the CM at the front desk and take up all of their time, what they do is they go online and they do an electronic spinner wheel. So they press a button and it pops up and says you've won this. Now this is one I actually programmed on the weekend. It's really simple to do. Even more interesting is that the commercial companies have gotten hold of this and gone, they've just done it, they didn't wait for us. And so you can download an app called Dynamicare, and you can do remote testing where you do a saliva test or a breath test. You do that remotely. You take a photo, uploads, the robot says, yes, it's Simon or it's Shalini doing the test, and then it comes back and you get a whole lot of points, which translates into a cash reward. It's also, with this increased interest, in the UK, they've been trialling it, not just to look at substance use, but to see whether we can use it for other things. So Nicola Matrebian, who's also one of our expert panel members, has used it to look at whether or not you could increase Hep B vaccination, because they had a problem with people doing one vaccination, not coming back for the second or third. And they got really dramatic effects. 12 times the odds of completing the vaccination schedule by giving just £10 per vaccination. It's a very simple incentivization that was very effective. So what we thought was, seeing all of these different models of care are coming out, we wanted to do a bit of a scoping review to see what was out there. And this is what I'm presenting today. It's just the tip of the iceberg, if you pardon the pun, because we thought that we would do this and get 20 studies, or maybe up to 60. And actually, what we got were 174 evaluations of contingency management, and 267 different CM interventions had been evaluated. So what I thought I'd do today is just give you a bit of a taste for what we found in terms of methamphetamine. Before I do that, I'll say that most of these came from the USA, 83% of them, in fact. And most of them looked at substance use. You'll see here, very few of them looked at other things. And here, what you'll see is also, not only did they all look at substance use, but actually quite a few of them looked at stimulants. But when you can see those 3 bars there are mostly for stimulants, all for stimulants, but actually not that many looked at methamphetamine. So most of them are looking at cocaine because they're from the USA, or cocaine and opioids. And when we drill down into the CM trials, there are only 8 trials, and they've evaluated 16 CM interventions. So basically these are 8 trials, and they might have had more than one contingency management arm on them. So all up there's 16 in different interventions. All but one were from the USA. They all targeted abstinence, so urine testing for stimulant use. Whoops, sorry. They were all in person. There are group CM models elsewhere for other drug use, but not for meth use. And they all involve that very classic escalating reward schedule with a reset. Only 3 of them were prize draws. So basically the rest are what we call classic voucher-based CM. And interestingly, they all provided vouchers, monetary vouchers, which you can hand in to get cash, but only one provided cash. Whereas when you look at the tobacco literature for CM, a lot more of them use cash. With illicit drugs, not so much. And most of them do it in the context of usual care. So it's not a standalone intervention. They're also giving psychosocial support as counselling. So not surprisingly, most of them found positive effects. So these studies here with the green arrows showed benefit, and that was a significant benefit. And this is very consistent with the literature. All of the systematic reviews show treatment benefit. Concerningly, one of them actually found that people got a bit worse. It wasn't so good. This one just had mixed findings. It wasn't very clear what was going on. But overall, the CM worked, so it's not inconsistent with the benefit. This was the only one that was kind of stood out as being different. And this was done in Cambodia, and it was a conditional cash transfer, small amount of money for giving people if they handed in a stimulant-free urine. And this found benefits in terms of reduced methamphetamine use, but it was a step-wedge trial design, so it's very unusual. And it was in the context of a much broader intervention around HIV prevention. So it's appealingly simple, but whether the benefits are actually due to the CM or the broader intervention, we don't know. So in conclusion, most of the models that we have for CM for methamphetamine use, there's actually not that many to start with. And none of them have been done in Australia. And none of them use these more innovative methods or focus on anything other than abstinence for methamphetamine use. So, I mean, here at the moment when we're talking about CM, we're quite interested in looking at different models and how it can be applied. For example, people are saying to me, can we get rid of that escalation and reset because people aren't going to like that? Can we do it in a way that's not abstinence-based? So essentially, I guess what I want to flag today is that we don't know the answer to these questions. And we don't know whether it's going to work here in Australia under these different conditions either. So if we are going to adapt CM for Australia, I think we're going to have to evaluate it here as well. So I don't know whether we have time for questions, or maybe we want to wait until Simon does his talk, because... Oh, I was just going to say, Simon's going to be up talking next about the perspectives of people who use methamphetamine on this particular treatment. Okay.
Thanks, Rebecca. And I'll just introduce, we'll go straight into Dr. Simon Clay's work, which, yes, is looking at participants' experiences on the same study. So we'll have a couple of questions after that.
Thank you for having me. It's a pleasure to be here. So, yes, today I'm going to be talking about a group of qualitative interviews I did with people who use meth to hear their thoughts and opinions and sentiments about CM. Do they like the sound of it? Does it sound terrible? What do they think? So firstly, I'd like to acknowledge the wonderful team of people that worked on this project. You have been instrumental. So I interviewed 30 people recruited from around the country, and the only criteria for entry was, have you used meth at least weekly in the past 6 months? So we wanted some kind of degree of frequency of use. When I sat down with participants, I gave them a short introduction of what CM is, to give them an idea of what it might feel like. So I told them that they would come in and give a drug-free urine. If it was negative, they'll get a small amount of money. The next time they came in, if they could give a drug-free urine, they would get some more money, say $5 on top of the other $5, so $10. That amount of money would keep going up for each consecutive drug-free urine you could give until you reached a cap. If you didn't provide a drug-free urine, then that would go back to zero. What do you think? People loved it. People were really excited. The main reason was they said there's nothing out there. At least with heroin, you've got methadone, but for meth, there's nothing. I've gone to my doctor. He said, I don't know, you're on your own. A couple of people had said, oh, you know, I tried modafinil. I tried Dex once, but that was for this. I tried a couple of antidepressants. Nothing really worked. So there was a lot of curiosity as well, and a lot of hope. People thought, finally, this is something that I can move into a new direction with. So people were given 4 different types of payment options. As Rebecca said, there's the voucher-based system and the prize-based system. There was an overwhelming preference for the voucher-based system, particularly in the form of cash. The main benefit was there was a sense of freedom with cash and also a sense of trust. The clinics were giving you cash and they were trusting you to use it for necessities, for food, for taking your family out to something nice. And that was really valued. The other side was gift cards. There was a sense of safety, a protection, a safety net, that you could only use it at certain places. And while the example I gave was a Coles Myer gift card, where you could spend it at a variety of different places, universally people spoke about it as a food voucher. I would go and get food for my family. I would be able to pay the groceries for this week. In terms of lottery, people were very ambivalent about this. Some liked it, thought it was kind of cool. There was the excitement of going into a lottery. There could be the communal aspect of it, you know, going to the clinic, spinning a wheel, having people say, yay, you did it, you got, I don't know, 20 bucks. Others thought this is highly unethical. You're dealing with people who have a history of substance use and addiction, and you're getting them to gamble. This is not the best way of going about doing this. Only one person mentioned the prize draw, which is significant in itself. So the fact that no one else spoke about it it's interesting. I don't know what it says. No one really had concerns about the escalation and reset structure. The only concern people had around failing a drug test was the shame and embarrassment of it. They said, I would know that I'm going to fail the test and I'm going to feel bad. I'm going to feel like I've let down the clinic, I've let down myself, and I don't want to do that. So there was no real concern about, oh, you know, I'd be bummed that I wouldn't be getting $30 this week. It was always about the stigma associated with drug use. There was a huge preconception that everyone would cheat, that you would be the only one who wasn't cheating, everyone else would be taking advantage of the program. And it was interesting because it didn't bother them. They're like, they're going to do what they're going to do. If I'm going to do the program, I'm going to do it properly and I'm going to do it for myself. There were a couple of people who said, I would be concerned that I might work the system, which is using drugs in between tests in a strategic way so that it wouldn't show up on the tests. And this was more about, I really want to do this and I'm scared that I'll slip into these patterns and I don't want to do that. So it wasn't a skepticism against others. There was a big perception that the program was worthless. $5 to try and get off meth? I don't want to do that, that's stupid. But after I worked with them a little bit and said, okay, well, you know, after about 2 weeks, if you maintained abstinence and you were getting $30 for each drug test, that's $60 each week. That's $80 each week. You know, that's not bad. And they said, actually, you know, that isn't bad. So it's important to do some reframing around the value. There was some perception that CM was coercive, but it was very, very minor. There were some people who thought, oh, it's a bit icky, I don't know. I just feel like you're inveigling people into testing, but there were only about 2 or 3 participants who said that. In terms of the testing location, participants were given 3 locations. They could either do it at home or do it remotely. they could go into a pharmacy, or they could go into their clinic. The overwhelming majority voted for remote testing, mainly because of the convenience and the privacy. They didn't have to go out. People wouldn't have to see them going into a clinic. They would be able to do it anywhere, so it would allow for greater adherence to the program. There was some interest in doing it at a clinic, mainly because of the social connection. You'll be getting them out, you'll be breaking them out of these potentially isolated social circles, and you'd be putting them in contact with support services. So the testing was quite minor in that regard. And it was, so that was the main benefit for clinic testing. Pharmacies, people didn't really like it. There were a few that said, yeah, it could be all right, but yeah, there was a greater preference towards clinic testing and at-home testing. In terms of frequency, there was a huge division. Some people wanted more because it would allow for greater adherence and encourage them to pursue abstinence better. Some preferred less because they knew that they would fail a couple of tests, but they still wanted to engage in the program. So having less testing so that they would be able to use once or twice a week, but still stay in the program without constantly failing, felt really good. A couple of participants expressed desire for a flexible testing regime because they did lead a busy lifestyle and they did want some kind of wriggle room. But there was this tightrope walking when it came to testing. If you test people too often, it would make the program undoable and far too difficult. But if you did it too little, everyone would take advantage of it and you're just giving out money to people to use drugs, and that's not what we're here for. In terms of treatment goals, abstinence was the main one. People had been using meth for such a long time, they wanted out. They just wanted to find a solution. They had been trying for a while and they were just done. Harm reduction was a goal for some people. They said, my use is pretty fine. I've got a job, paying the bills, I've got kids, taking care of them. So if I could have a program that could allow me to use in a more balanced way, that would be amazing. Finally, do I have one? Yes. Pharmacotherapy was a huge one. People said this program will be undoable unless you give us medicated withdrawal treatment. I don't care what that is, but withdrawal is horrible, and unless you can give me something on top of the money, I'm not doing it. Furthermore, counselling and peer support engagement was massive. People said this program is useless unless you have all those social systems in place and community engagement to break people out of the isolation that often comes with long-term substance use. And I think I'm out of time. 1 minute, finally. While we only had 3 gay men in the sample, they had a very, very unique experience. They spoke about how because meth is so accepted and so ubiquitous within the gay community, that presented a challenge, as well as meth had been such a major part of their intimate life, their sexual relations, their romantic relationships, that a life without meth was almost unimaginable. They would have to reconfigure the way that they related to themselves, the way that they understood their own identity, the way they connected to their community, the way that they went about meeting new people and having more intimate relations. It was impossible to imagine. So having extra support systems for gay and queer men is going to be vital for an effective CM model. And I might wrap it up there.
Hi, thanks for that. That was really interesting. I'm wondering about the choice of abstinence as an outcome and whether that has to necessarily mean that it's presented to participants as being abstinence is their eventual goal in therapy. Because I guess the way my group conceptualises it tends to be that it's a period of abstinence, and that is part of the intervention. So that then following the period of abstinence, which is what's reinforced along the way, they then make the choice as to what they want to do after that. But the abstinence itself serves as a bit of a signal detection between use and not use, so people can really experience the differences.
Yeah. I found that there were three main groups of participants. There were some who wanted permanent abstinence. They just needed some kind of stepping stone to get there. People who did want abstinence, but harm reduction would be the best way forward for them. They wanted something to reduce their use, particularly people who had been using for 10, 20 years, who had tried abstinence before and it hadn't worked. They just needed something to help them cut down their use with the goal of being abstinent at some point. And then the people who were quite happy to still use and just wanted something to allow them to manage their use a little bit better.
So I guess I wonder what they would think about it if it was presented as something rather than being an abstinence-focused intervention, but that part of the intervention was abstinence, and there would be a period of abstinence following which they could decide what to do.
Yeah, I mean, I guess because the program would only run for 12 weeks, I think we said after that they'll be free to do whatever. But yeah, there was the hope, and this is another thing, people said unless you've got support afterwards, people who want abstinence will probably fall off. And we need that continued support for those who do want to continue.
Thank you.
Thank you. This is for both Rebecca and Simon. I was just wondering if you looked at any of the theoretical frameworks behind contingency management and whether they were either explicit theoretical frameworks or implicit, because so many of the frameworks we use in public health are so individualised. Yet what you're saying, Simon, is that, you know, that actually people were considering contingency management much beyond just the self. So just interested if that was part of the systematic review or your work.
Yeah, it's a good point, Anna. Certainly the theoretical framework for CM is operant conditioning. It's an individual focus. It doesn't take into account all of those contextual factors. With the scoping review, we looked at what other supports were provided for people, and we're finding that most of the other programs that have been implemented have provided some additional support as well. But it's a good point, and that's one of the criticisms, is that, you know, it's specifically addressing the drug use, and you can target other behaviours, but it works when it targets one behaviour, not when you try and do a whole gamut of things. There are community reinforcement models that are similar, but are more about reinforcing pro-social behaviour. So kind of like, you know, you come to the group and you contribute and the reward is a bit softer. So there's those models as well.
Thank you. Thank you to both Simon and Rebecca. Next up, we have Joanne Lunn, who's presenting on feasibility.
Hello. So we're looking, sorry, I thought there'd be a computer here. Okay. We're looking at the feasibility and preliminary efficacy of the cognitive remediation groups in a community outpatient setting for people who use methamphetamines. Okay. Before I begin, obviously I'd like to acknowledge the traditional custodians of the lands upon which we meet, and also the lands upon which the University of Wollongong is situated as well. And as we go through acknowledgements, there's an enormous number of people that have been involved in this study. I particularly want to acknowledge Kerry Wallace and Tracy Malin from ISLD, who not only learnt an entire group protocol, but also a new group work delivery mechanism, which I'll go into a bit later. And I'd also like to say that this study is actually part of a much larger study that has been going on for the last 12 years. So it's had over 1,000 clients have had their input into the various elements of this study. Multiple staff, multiple students, enormous numbers of people. So we really need to acknowledge the amount of people involved, and of course the Agency for Clinical Innovation. So the aim of this study was to examine the feasibility and preliminary effectiveness of the ACE cognitive remediation groups for people attending outpatient treatment for methamphetamine use. So that rather big mouthful is all about looking at why are we looking at cognitive impairment or cognitive remediation in general. Why? Because previous research has demonstrated approximately 50% of clients accessing drug and alcohol treatment will have cognitive impairment. Of those with cognitive impairment, 75% will have moderate to severe. Now what that means is generally executive function, so that is decision making, that is problem solving, that is impulse control, and that is emotion regulation mechanisms are affected. So if you think about somebody who's trying to change behaviour, the importance of those factors cannot be underestimated. So the whole idea of the cognitive remediation is basically as a support mechanism to support existing treatments that are in play, whether somebody's going for abstinence or whether they're going for harm minimisation. So what have we found in the past? So the ACE cognitive remediation group work, as I said, has been around for a fair period of time. Most of the work that we've done has been in residential services. And one of the things that we found, this is the large study, 526 people, where the general staff, so that's existing staff members, not specialists, implemented the ACE cognitive remediation group work. And what they found is that there was a significant improvement in cognitive function post the group work. So we're talking 12 hours of group work delivery over a 6-week period. And we managed to reduce the cognitive impairment rates by half. And if you think about the risk factors for this group in terms of head injury, overdose, intellectual disability, learning disorder, it's pretty impressive results. The other thing that we actually achieved with this, which was sort of like the hallelujah moment in residential treatment, was we actually were able to increase retention, right? So retention went from 34% to 63%. So that's kind of like the golden chalice in residential treatment. So what we wanted to do in this study was to look at what happened when we had a methamphetamine-specific client group, but also what happens in outpatient, because outpatient is very different from inpatient. As we've talked before about residential services basically having a captive audience, so to speak, what the hell happens when people are free to come and go as they please? Well, our project blew up because there was a worldwide pandemic and we were looking at group work, which was a little bit of an issue. So what we actually had to do was we had to change our complete assessment processes. So all of our assessment then had to be changed and switched over to an online component. The other thing that we had to do was to actually look at a different mechanism for group work delivery, because even in our local area and local service, we're in Wollongong, so we were part of all of the joyous, unfortunately, we were no longer a regional bloody area. We were considered as Greater Sydney, apparently, under COVID pandemic rules, which meant that the whole health service shut down. So even as things improved, the room size that we were using, we're looking at a maximum of 4 participants. So anybody who's done an outpatient group setting, if you want to have 4 participants turning up, it's a little bit of an issue. So what we had to do was, thankfully with the help of Southwest Sydney, we're already looking at changing or modifying the resources. They'd funded a program to do that. So we looked at utilising these new resources and we got permission to do that. So instead of having 12 sessions over 6 weeks, it was 5 sessions over 5. Most importantly is these new sessions had actually been designed for online delivery. So they could be delivered either online or face-to-face. Each one of the sessions contained at least 1, if not 2 short videos, as well as brain games and the things to keep people engaged. The other thing that's really exciting about this new group work, not that it was done in this context, but each one of these groups is a standalone session. So one of the big issues, obviously, in terms of delivery of group work, both outpatient and inpatient, is the need for, if you've got sequential groups, at the end of your group work period, you have a couple of people left and you miss out on a lot of numbers, whereas if you've got open sessions, it makes facilitation a lot easier. So our new project timeline, we've run 1 group cycle so far. We're sort of halfway through the second. we'll be running the third group starting this month. Hopefully, we'll get the write-up by March 2023 is the plan. So our participants. So far we've had 43 people approach to participate in the study. So the criteria was around they were accessing the local Illawarra service, Illawarra Shoalhaven LHD. Their primary substance use had to be methamphetamine, and they were actually screened using the ACE cognitive remediation screener. So that just gave an indication of potential cognitive impairment. So when they were screened, they were given information about the study and asked to participate. So 43 people were approached to participate. Of those, 23 people agreed. And of those 23 people, we've got 10 that have got to at least one group. So in terms of, and what we've found is the issue is not getting them to stay in the groups, ironically, it's getting them to the first M group, which is the really tricky, seems to be the really tricky component. So in our first group, which has been completed, we had 4 attend one group and we had 2 complete. So, which is 50% of 4 people, so we'll have to see how that keeps going. And then we've got another group that's currently underway. We had 6 attend one group and 4 have been regular attenders. So what are the key learnings? The most important thing about this is that it is actually feasible to and acceptable to clients to facilitate this group in a community outreach setting. It's hard, it's really hard to get them from, being interested in the project to actually attending a group. But the other thing that we've found that's really exciting about this, if we get them to one, we're likely to keep them. And one of the things I just want to, put this in perspective, these are people that are staring at their phones for an hour. Right? So people with cognitive impairment and a methamphetamine issue that are staring at their phones for an hour and they're attending, 6 out of 10 groups. So I think that in of itself is actually speaking to the quality of the presenters and also of the resources. So the other thing that's really important about this is it's showing that it's feasible to do it online. There's lots of questions about that. People with cognitive impairment accessing their phone to actually attend a group online. I mean, we've all attended sessions where it's like, you're on mute, like all of that kind of new world that we've had to live with. And they've actually been able to navigate it quite successfully. Out of the people that have dropped out, I think it's about 2 had technical issues, and that was due to internet access at the time. The other issues once they've started, and the reason that they tend to drop out, has often been around sickness or child sickness. So we ran these groups when there was a surge of COVID issues within the Illawarra, so everybody was sick, and if it wasn't COVID, there was the type 1, influenza was also going around at the time. So there was huge issues from a sickness perspective, but people were still able to attend. And that was the other thing, obviously, because even though they were sick, they could still attend because it was online. So the other thing is obviously maintaining people online, right? So if you've got people with cognitive impairment, it shows that if you're going to do an online setting or online format, you really need to think about how are you going to do that, how many people can you actually have in total, how to teach people how to use online things effectively, and also obviously if somebody's intoxicated, how's that managed on an online perspective as opposed to face-to-face is quite different. And there is definitely a need to attend or to develop open group formats for people to increase attendance. So future directions for this project, we are going to be doing the open delivery, also open format delivery, and there's a study that's going on with Odyssey in Southwest Sydney. And the other thing that we've got is an electronic or completely electronic assessment now moving forward. So there used to be a facilitator required assessment of cognitive impairment, which is now going to be flicked over to online. Okay, thank you very much.
I'm interested in the demographic makeup of the groups. Was it majority men or did you have females attending?
It was
as
majority women, and the other thing that was really important is women with children who wouldn't normally be able to access group work because their kids would have prevented them from being able to do that. So it was really important from that perspective. Yeah.
Thank you.
Okay, thank you, Joanna. Next up, we have Dr. James Gooden, who is also an NCCRED Clinical Research Scholar. Yes. Yeah.
Thanks very much. So, yeah, my name is James Gooden. I'm a senior neuropsychologist at Turning Point, and today I'll be talking on our findings from our neuropsychology clinic, and specifically looking at individuals with histories of methamphetamine use. So I want to start with a quick referral question. So client has difficulties with memory, query ABI due to methamphetamine use, please assess. And inevitably, when we start digging into a history like this, we always find it's far more complicated than just simply that question. And this is due to a range of biopsychosocial factors that are often very relevant to cognitive functioning, but are very easily overlooked, both in clinical settings, but also in the research literature. And one of the big issues we have as clinicians is trying to adapt the findings from the research literature into clinical practice, because often these variables aren't well accounted for or well recognized. So the aim of our study was to explore this clinical impression and clinical anecdotes that we were noticing in the clinic, and to explore the biopsychosocial factors and neuropsych profiles of individuals reporting histories of heavy daily methamphetamine use who are presenting for assessment at our service. So these were all clients who attended for assessment at our service in Richmond, Melbourne, and we conducted a retrospective case file audit of individuals where we extracted all of their clinical histories, assessment scores, our clinical opinions, all from their assessment reports. And we pulled out individuals who reported a history of daily or near daily methamphetamine use, either past or current, for at least 1 year. So anyone who met that criteria were pulled into this data set. We didn't apply any other exclusion criteria because we wanted this to be as sort of clinically relevant as possible for this group. Out of interest, we compared this group to a group of individuals with alcohol use in a similar criteria. So a lifetime history of daily or near daily alcohol use with no other illicit substance use history. And we wanted to see if there were any sort of different or unique patterns among these two groups. So we found a group of 40 individuals with methamphetamine use and 27 individuals with alcohol use. The one exclusion criteria we did have was that they did have to present some degree of, they had to have valid neuropsych assessment scores. So anyone with issues around effort or malingering, for instance, were excluded. We then conducted a range of between group comparisons for a series of variables to see whether any interesting profiles or patterns emerged. Now for the methamphetamine group, some of the key demographics that came up, and it's interesting to see some of the demographics reported over this morning, the last few talks, and seeing some quite similar patterns as well. But one of the key ones is around education, so around 65% reporting a less than year 10 level of education. And that's very common with our wider cohort that we see in the clinic as well. Very high rates of psychiatric comorbidity, so 70% in total reported a history of a formal mental health condition, with rates of depression, trauma, anxiety, and psychotic episodes all being very common. As well, we had high rates of neurodevelopmental conditions, so around 22% reported a diagnosed neurodevelopmental condition, including things like ADHD and learning disability. And these are significant because from a cognitive perspective, these are conditions that a person's obviously been born with and carried throughout their lives and may well account for a range of cognitive difficulties that they might be experiencing. Some of the neurological risk factors for acquired brain injury are presented there as well. So only about 5% had a traumatic brain injury of a moderate or more severe level of injury. Whereas around 42% had histories of a concussion, so the mild end of the scale. It sort of highlights the degree of maybe misadventure, getting involved in sort of assaults, things where there's that risk factor for sustaining a more severe injury. As well, around 22% had histories of overdose. So there's a range of factors there that could be relevant to both future risk if that behaviour sort of continues, but also the risk of sort of ongoing cognitive difficulty on that front. We also had rates of untreated hep C, again, which is relevant to cognitive functioning in the long term if left untreated. And that's significant considering how easily treated that is these days as well. One of the most interesting findings for me was for this group was around 55% reporting patterns of daily alcohol use in the past, with a mean standard drinks of around 87 standard drinks per week, so around 12 per day during the heaviest period of use. So that's actually well within our rules of thumb for an alcohol-related brain injury, depending on how long they might be drinking at that level for. So that highlights that when we think about cognition, we have to think about past histories and past patterns of use as well, and not just the most salient drug or what they might be using right now, because it's all potentially relevant on that front. When we conducted a range of between group comparisons, a couple of interesting patterns emerged. So the methamphetamine group in particular were significantly younger, male, with an earlier age of onset for alcohol or other drug use. They presented with more overdoses, hep C infection, as well as offending history. So around 87% reported a history of offending or legal involvement in the past. For the alcohol group, they had significantly higher medication sedative loads, so the amount of prescribed medications that they had that had some degree of sedating component, which highlights that potential risk for synergistic effects associated with alcohol. And of course, they reported more drinks per week during the heaviest period of use, so 175 standard drinks per week, so around a bottle of whiskey a day, roughly. Notably, equivalent rates of psychiatric, neurodevelopmental, or acquired brain injury are comorbidity across both groups. So it highlights that that's not necessarily a unique feature of the methamphetamine group. It's pretty consistent across both groups, and certainly our research from the broader cohort as well. When it comes to cognition, we found that the alcohol group performed significantly worse on overall IQ, psychomotor tracking, and semantic verbal fluency, but overall fairly similar performances. One thing that was notable was both groups performed largely in the low average range relative to normal data. So you can see that normal range is highlighted in blue at the top there, and both groups are kind of shifted down into that lower average range. So, in conclusion, these data really do highlight that a number of biopsychosocial vulnerabilities were identified in the group of individuals with methamphetamine use histories and were presenting with cognitive concerns. I think for me clinically, one of the concerning features is the fact that these difficulties were present at a younger age than the alcohol group, with that higher risk of harm associated with polydrug use as well, so overdoses, injecting behavior, and so on. One of the questions is, does this represent a different trajectory to other drug groups, for instance? So are they following that trajectory but shifted down at a younger age, and therefore what does that mean for the future? Or does this reflect sort of differences in illicit versus illicit substance use as well? So, are that alcohol group, for instance, just skating under the surface and presenting to services later because they can kind of get away with it for longer? And there's the differences there with the corrections involvement, for instance. So, does that reflect getting involved in that legal system more and therefore coming to the attention of services? The alcohol group performed marginally worse on some variables of cognitive functioning, which is probably what I would expect given the neurotoxicity associated with alcohol and cognitive functioning and the good evidence we have on that front. I was expecting probably some more differences, but anyway. I do have to highlight a couple of key limitations with this data. One was that these are fairly small group sizes. It's a clinical sample set, not a research sample set, so it is messy. It's triaged to those who needed to see us for an assessment, and coding and quantifying all those issues is inherently complex. We are also a community-based sample, so we're not seeing that really severe end at the hospital inpatient level as well. So some key implications. Firstly, diagnostic formulation is crucial considering this highly stigmatized cohort. We really need to be careful around drawing assumptions and start thinking broadly around those biopsychosocial factors that are relevant to cognitive functioning in these groups. Most importantly, because many of those might be treatable. And so that's where we need to advocate for multidisciplinary input to ensure that we're addressing as many factors as we can before just throwing on labels like a brain injury, for instance. And for researchers, I want you to embrace that complexity as much as possible, as much as feasible, because we need these findings and research to be applicable to those real-world clinical sample sets that we're dealing with. So I hope that's not too controversial to request. But I would like to acknowledge all my co-authors and colleagues and funding from NCCRED as well in supporting this work. Thank you.
We are running a bit behind time, but are there any questions? I'll let you pick who, Liam. Who wants
There you
to?
go. That's all right. You're much more esteemed than me. Thanks for a great presentation, and congratulations on, I guess, bridging that gap between what we often see in research and what happens on the ground. My question relates to the offending kind of data, and I wondered if you had any sense of whether or not that offending was primarily actually just possession offences, or what happened first in that sense for many of these people.
Yeah, so the offending history, we do get a lot of referrals from correction sources. So around 50% of referrals from our clinic are from correction sources. So that's probably why we're seeing that. It's split. There is a range. There are quite a high proportion of individuals presenting with violent criminal offending histories. I can't give you the exact figure. There is a past paper that we have looked at on the types of offending. But yeah, a broad range. So not just possession, there are a range of other offences, yeah. Thank you. Happy to take any questions later.
Thank you, James. And we also have another NCCRED Clinical Research Scholar, Jason Ramp, who's come from Port Augusta? Port Lincoln, sorry. Port Lincoln. There you go.
Hello. I'd like to acknowledge the traditional owners, the Ngunnawal people. Basically, ice has had a huge impact in Port Lincoln. In response, we've started a dropping centre called the Healing Circle. It's been running for a year. During that year, we've shot a documentary, and yeah, basically we're going to play the documentary, and hopefully that portrays everything about the centre. Thank you. Is there anything you want to say?
Well, we start off first thing in the mornings. We come in, we sort of everyone gets settled, sit down. We'll have a little session with the DIG, sort of like a little meditation session. Once the DIG is finished, we sit around and we sit in silence for a minute or so.
The Healing Circle has been like my new family. I've come here to get help because I didn't have family to really fall back on. Healing Circle has been a great place for me to come to openly talk and trust people about past things. Methamphetamines, ice has been a big problem here in Port Lincoln. Need to get out and reach out to the community, people, that there is help and support out there and they're not alone.
There's always an underlying factor as well. You're trying to cover something up as well. Like, there's always underlying problems that you're trying to make yourself feel better about. Meth you used to be able to use every day, go to work and control everything. You use ice a couple of times and it's just so much stronger. You cannot hold a family, you can't hold a job.
you started feeling like you're invincible to people. Like it doesn't matter, you felt like you're 10 foot tall, built like a brick shit, and that nothing could tear you down. Like once I got the good feeling of after using injecting it, the traumas that I experienced as a child, the abuse that I'd been through as a child, all that sort of stuff, it just made it all go away.
Yeah, when we decided to open up Circle, we didn't really want to have so much structure and routine about it because we were worried that having too much structure might scare people off and, you know, not want to have them in a setting where they have to have so many guidelines and rules. You know, we wanted to have it a little bit more formal and just rock up and sort of get comfortable, and if you're willing to talk, you can talk, and if you're not comfortable talking at the start, then have a couple of sessions, and most people are pretty comfortable to open up after the first session. So have a cooked lunch each day. If it's nice weather, I like to put the barbecue outside and crank the barbie up, or if it's a bit cold, then we'll cook like casseroles or spaghettis and things like that, and do takeaway meals with what's left over. We can give out to clients that might not have something warm to eat for the night.
A couple of them that haven't turned up today. I thought we'd see Marcus. It makes you feel like you're cooking and preparing food for a family. So that's why I always call this a home. We all come together as a family and support each other. We make meals, we get out in the art room, we do our painting, I learnt how to do origami butterflies here for my mum's funeral.
Keeps you high, so yeah, I find it very hard to sleep. I find it very hard to keep still and overthink and just, or sometimes not only thinking one thing, I'll probably be thinking 5 or 10 things at once.
I've been using the We Can Do It app for probably roughly 2 years. That's probably one of the best things about it is if people aren't able to get to see like a proper drug and alcohol counsellor or somebody that's got experience in that field, then they can jump on the app and there's people that can help you with it as you go. Who could you tell?
Someone I could trust, or someone that I trust.
Talk to me. Using the We Can Do It app with Kenny was pretty good because I'd already used it, so it was good to be able to sit and watch somebody do it, and if they had any trouble they could ask me what to do, and working through it with somebody else was good too because I could see how they dealt with it as it come up, you know, if it was straightforward for them.
It does go on a little bit, but we'll stop there in the interest of time. I'm Rachel Riley. I'm a Senior Research Fellow in the Wadley-Paringa Aboriginal Health Equity Unit at SAMRI, and I've been working with Jason, or supporting Jason with this project. So just a little bit about the research side of things. She worked with a First Nations researcher from Canada recently who described researchers as story catchers. And I really, it's been such a privilege to work on a research project which gives a whole new meaning to that idea of research. So what you've seen is a small part of the work that Jason's been doing. He's done several interviews with people at the Healing Circle about their experiences and their use of the Wadiwanti web app, which was previously We Can Do This. Wadiwanti is a Anangu word, which means leave the ice alone. We're analysing those interviews thematically, which presents a new challenge, having visual data as well as textual data, so that's something we're learning about together. then with the permission of the participants, the interviews will be incorporated into the web app or into the supporting resources for health services who we're hoping will use the app into the future. And we've done a brief small-scale survey of implementation needs in 3 Aboriginal health services to see what sort of supports they might need to incorporate a web app like this into the work that they do. And there are several people to thank. In particular, I guess the clients and the staff at the Healing Circle. Did you want to mention anyone?
Yeah, just SAMRI, NCCRED, Joe Clark, Josh Callis, and yeah, I think that's it. Yeah, and you as well. But yeah, it feels like it's been a real success, and you know, the power in the place is just connecting with other people who got the same problems. So, you know, that's why we don't have any sort of formatted rundown. The only thing we have is like 10:30 is be there for the dig playing, and that's when we do the workshops. And we cook lunch every day, and I find that that makes people turn up, and people talk when they're eating as well. So a lot of information gets exchanged there, and you know, that's the power of the place anyway. It's more like a home, yeah. Yeah, but that's it. Thank you.
Thank you. Rebecca Lang from the Queensland Network of Alcohol and Other Drug Agencies. First of all, I'd love to get the recipe for that pie that was in that video because it looked real delicious.
I was on a diet when I was editing that, and I was,
yeah.
That pie tastes good, I ate.
The struggle is real. I'm really interested in, because obviously one of the things we've noticed about people who access alcohol and drug treatment is that nutrition is a real issue. So the lunch part of that is really interesting to me, but also the getting people there. So part of the doco was the bus doing the rounds. Is that how most people get to the centre?
Yeah, probably most of them get there during the bus, through the bus, and we have quite a few people who just walk in off the street as well.
Yeah, it's a really great example of how just hitting those little, like making it easy for people means that they'll engage a lot more fully. So really well done.
No, thank you. Thank you.
Now we have Dr. Bahima Lokuj and Taran Yadidov from University of Newcastle.
Thanks, everyone. My name's Budi Lokugay. I'm a staff specialist at Newcastle at the Drug and Alcohol Clinical Service, and I'll be co-presenting with my colleague Tarun Yadav on behalf of our research team at Newcastle, and really excited to be talking about this because 2 years ago when Tarun and I sat with Prof Adrian Dunlop and thought about whether we can bring this modality of transcranial magnetic stimulation, which was commonly used in the private sector the last few decades, but not so much in a public outpatient drug and alcohol service. We imagined there'd be lots of challenges, and so excited to be here to talk about the 8 patients that we've seen and recruited and who've been through our treatment. How do I change the slides? Oh, yeah. Here, Nicole. Oh, okay. So this is a feasibility study. What we wanted to understand what would be the challenges of bringing a modality like this into the public sector, understand the complexity of managing clients with comorbidities, and get a sense of how we could implement a larger trial if there was benefits and evidence for that. Tarun will talk a bit about the rationales and the reasons we decided to do this, but essentially, in essence, it was a feasibility study. We wanted to have 2 arms, a randomized arm with a sham treatment, so an active TMS. Essentially, TMS, for those who might not be familiar, is magnetic stimulation or induction of certain parts of the brain in a non-invasive way, and we've targeted 2 parts as part of this trial, which we think might be relevant and helpful in treating substance use disorders. And for the feasibility, what we wanted to see the difficulties of a double-blinded study. So we had a sham arm, and as part of the sham or the non-active placebo arm, we had something that stimulates or simulates both the sound and the skin sensation of TMS. It's essentially the treatment involved 12 treatment sessions, so we're interested to see how participants would engage and participate. Three treatments in a week over 4 weeks and study assessments. And as part of that, there was an opt-in counselling or standard of care, essentially with CBT, a standardised CBT protocol that one person delivered in the 4 weeks, once a week, and then an opt-in neuroimaging study. And as part of developing this protocol, we also involved Martin Neen, who's the head of our Aboriginal Liaison Unit, in doing an impact statement and understanding how we could ensure that we could recruit and ensure access to a proportionate number of participants who were of Aboriginal and Torres Strait Islander descent. Children?
Thanks, Buddy. Hi, everyone. As Buddy said, I'm the specialist with Drug and Alcohol Service in Newcastle, and I have a psychiatry background. So talking about the rationale regarding using TMS, so I've been thinking about TMS for a while because I've been using it for treatment of depression for the last 3-4 years in my private practice as well. So TMS is transcranial magnetic stimulation, so it's a non-invasive way of stimulating the brain cells. It's basically delivering magnetic pulses to the brain. And depending on the frequency and the duration of the treatment, you can either overstimulate or make a part of the brain more active, or understimulate or make it less active. And that was the idea we used. It has been a treatment which has been used in depression for almost 2 decades, and it's relatively well tolerated and safe treatment. It's been effective as well, but there have been recent sort of, I guess, interest in using TMS in addiction, and there are a few sort of trials already happening, and there's already a protocol being used in US for the smoking cessation, but it's all been studied in alcohol, cocaine, opioids, and cannabis. So we thought, why not consider this for the methamphetamine use as well? Okay. To the right. Oh, okay. All right. So the way we were thinking about is that there are 2 main sort of pathways involved in the addiction. We wanted to enhance the executive control using or targeting the dorsolateral prefrontal cortex. And then we thought if we can somehow also reduce the negative emotional state sort of, effects of the substance use by understimulating more of the deeper structure like limbic, but we can't target because TMS is very superficially acting. You can only target the 2 or 4 centimeters of the cortex. So Colin Henlon group in US did some trials to use orbital frontal cortex. If you target that, you can have downstream effect to reduce the activation of the limbic area. So that's what we thought. We're also using a theta bus protocol compared to the usual RTMS protocol, which is more like an advanced protocol where it's very time efficient and we deliver higher frequency treatment. So the treatment can be done in less than 5 minutes, basically, on each side. And then the way you use theta burst, you can either stimulate. So with RTMS, if you use higher frequency, you get stimulation of the part of the brain, or if you use lower frequency, you get the suppression. But with theta burst, you have to give it intermittently. So 2 seconds on, 8 seconds off, and you get the stimulation of the brain. But if you give the same treatment continuously, you get the understimulation of the brain. And then we thought if we can give intermittent theta burst to the dorsolateral prefrontal cortex to increase the executive control, and on the orbitofrontal cortex, if we give the continuous theta burst to reduce the limbic arousal. Yeah, and then also the added benefit of co-occurring like depression also improving, because some of the pathways we're using are common in depression as well. So for example, targeting the dorsolateral prefrontal cortex with theta burst is already an established protocol treatment. And we also thought, because the other thing which we have to look at is that how much stimulation we can deliver in a short span of time or over a period of time. So with our population, if we were to go daily treatments, it was difficult. So we thought, how can we do the same thing? So we decided to have, I guess, 3 cycles of the treatment. So they have the left dorsolateral prefrontal cortex stimulated and followed by the orbitofrontal, a 10-minute gap. And then we repeat the same cycle 3 times in the same day over a period of 50 minutes. And then we do it 3 times a week for 4 weeks so that we don't have to go for like a daily treatment, which is usually the recommended treatment in depression. And as Buddy said, the controls will receive have been receiving the non-active sham treatment. And the outcomes are, we had the feasibility, the safety of TMS in this population group, because we also knew there were some clients who were using other, I guess, substances which put these clients more at risk of, I guess, side effects, including seizure risk. Patient experience and neuroimaging sub-study, and then we'll also look at some preliminary efficacy data, including changes in substance use, cravings, and cognition. And Buddy will talk about the rest.
Thanks, Stearne. On the cognition side, we wanted to test 2 tests. One is a go, no-go test of inhibitory control or response inhibition. All these are quite demanding and can be tiring. We also have a cue reactivity exposure paradigm as part of it. And so in some ways, we're not sure whether we'd, in the anticipated sample size of 30, whether it'd be just me and Tarun in the lab waiting for people to come. In terms of the eligibility criteria, I'll just go back a slide. We were quite broad. We wanted to keep it broad so it was translatable and practical. In a lot of referrals came from our stimulant treatment program, but also our opioid treatment program. We decided, after discussion with a team of the investigators, that we wouldn't exclude other substance use disorders. So essentially, anyone who met the criteria of moderate to severe methamphetamine use disorder, had current use, and were happy to participate in the study, were eligible, but then as long as they didn't have one of the exclusion criteria. I've just summarised some of them, but the main ones were that there wasn't current treatment for withdrawal. Particularly, we were interested and would look forward to exclude GABAergic substances like alcohol or benzodiazepines or gabapentinoids that might affect seizure threshold. Particularly if they're in withdrawal, it might affect seizures with TMS. TMS, the safety profile is pretty well established. There's a lot of data and systematic reviews, but there's a seizure incidence similar to that of treating someone with antidepressants unless there's a increased risk of seizure. So having a good exclusion criteria around that was part of our baseline assessment. And then there were some mental health disorders as well as pregnancy and other exclusion criteria, and exclusion for TMS such as metal in the brain. So how do we go? So far we had 32 referrals. Time's up. Okay, very quickly, 32 referrals. 8 people started the study. The others had ineligibility criteria. 6 have completed, 2 are currently in treatment. And overall, there's been some, in terms of engagement, most people have completed all 12 sessions, so 3 times a week. It's interesting, there's been a lot of interest in engaging with a new treatment. And in terms of adverse effects, we've had 9, most have been minor and known effects like local skin irritation, and the 2 serious effects have been unrelated, such as assault and injury. Thank you.
Sorry, we are out of time so we don't have any time for questions, but I'm sure during afternoon tea, have a chat. And our final presentation for this round is a pre-recorded one with Florence Bascom, who is an adjunct lecturer with NCCRED. So I'm assuming that will be done from over there. Great.
Hello, I don't know if you can hear me or see me. It's not actually pre-recorded. Hello, I'm sorry I can't be there today. I am actually on the other side of the world. It's a very early time of the day, but really great to hear everyone's research so far. Just checking that everyone can see my screen. Great, okay. All right, so this is a training needs analysis for alcohol and other drug telephone helplines for calls relating to methamphetamine and emerging drugs of concern. Health problems related to methamphetamine in Australia have increased over the past 10 years. So too are issues related to emerging drugs of concern. Emerging drugs of concern include new psychoactive substances appearing on the market, such as novel benzodiazepines, novel drug classes that are potentially harmful, such as synthetic cannabinoids, and new formulations of older drug classes for which problems related to their use are emerging, such as fentanyls. Australia's alcohol and other drug telephone helplines offer first-line brief intervention, support, advice and referral to people who use drugs and concern friends and family members. The helplines answer about 100,000 calls a year, whilst telephone helplines can reach pockets of the community that other health services can't. They can improve access to care for people living in isolated communities, and marginalised people might find the anonymity of helplines attractive due to concerns over stigmatisation or discrimination. There is some evidence to suggest that telephone helplines support reduction of substance use and increase uptake into treatment. However, there are limited published guidelines available to telephone counselling services for methamphetamine. As new drug trends emerge, training requirements and resource needs should be regularly evaluated. To address this, we sought to conduct a training needs analysis to identify knowledge and resource gaps for alcohol and other drugs telephone helpline service providers for calls relating to methamphetamine and emerging drugs. The purpose of this training needs analysis is to focus the development of educational materials and resources. So we distributed an anonymous online cross-sectional survey between October 2021 and April 2022 to helpline staff from the National Network of Alcohol and Other Drug Information Services. These include the Alcohol and Drug Information Services of New South Wales and South Australia, AIDA's 24/7 Alcohol and Drug Support in Queensland, the Alcohol and Drug Support Service in Western Australia, and Direct Line of Victoria. And cumulatively, these cover as well Tasmania, the Northern Territory, and Australian Capital Territory, who contract out their services to Victoria and New South Wales. The training needs analysis was developed in two parts. The first part was based on the World Health Organization Hennessy-Hicks training needs analysis tool, in which participants rate on a 7-point Likert scale the importance of a topic to their practice and how well they perform in relation to the topic. Mean scores for each importance and performance item are calculated, with the largest mean difference indicating a greater training need. Participants were then asked to complete open-ended questions specifying their own self-perceived training needs in relation to specific psychoactive substances, caller groups, and barriers to training or accessing resources specific to methamphetamine and emerging drugs. And we used a descriptive content analysis to analyse this data. So a total of 50 people from an estimated workforce of 110 consented to participate. And this is estimate just because some staff work across multiple helplines, and we were trying to estimate FTE employees. Among them, 28 completed the full questionnaire and 18 returned partially completed questionnaires. Data obtained from partially completed questionnaires were only included if they contain responses to all items in the Hennessy-Hicks training needs analysis tool, which meant 10 participants were excluded due to incomplete data sets. So this left a final sample of 37 respondents for the Hennessy-Hicks training needs analysis, with qualitative and demographic data available for 29 of those 37. So here you can see the demographic characteristics and qualifications of the 29 participants who provided a full data set. The median age was 49 years and 62% identified as female. The majority of participants were counsellors, 68%, although some participants ticked more than one professional identity. The length of time they had been working in the alcohol and other drug sector ranged from 4 months to 42 years, with a median of 6 years. When asked to rate on a 7-point Likert scale the importance of each activity to the successful performance of their job, participants deemed all items important to success. High training needs were identified across 7 activities, which included accessing and providing up-to-date information on cathinones, fentanyl, and other novel psychoactive substances, accessing and participating in training related to methamphetamine and emerging drugs, and communicating with culturally and linguistically diverse clients in calls relating to methamphetamine and emerging drugs, and of borderline importance, promoting fentanyl testing as a health promotion activity. When asked to comment on particular emerging drugs on which participants would like further training, respondents listed a wide range of both established drugs and novel psychoactive substances. The most commonly cited were depressants, particularly GHB, stimulants, particularly cathinones, and opioids, particularly fentanyl and its analogues. When asked if there were any subgroups of callers that respondents felt required clinical skills strengthening to answer, families, friends, and concerned others were the prominent response, coded 10 times. Participants felt that they were expected to fix a problem for the caller and highlighted a level of expectation to have exact knowledge about methamphetamine and emerging drugs in order to offer the absolute correct information to them. Some of the complexity was attributed to misinformation in the media, influencing public perception of substance use disorders, and some prevailing prejudicial views. When asked if participants felt there were barriers to training or accessing resources in relation to methamphetamine and emerging drugs, respondents largely stated that there were none, or that they were not aware of either barriers or accessibility issues to training and resources. For the other participants, time constraints were a key theme. Others articulated a lack of awareness of practical population-specific information relating to methamphetamine and emerging drugs, treatment modalities and caller population groups that could be translated directly into AOD counselling calls. A number of participants suggested a dedicated ADIS database of emerging drugs resources could help with this problem. So to conclude, to our knowledge, this is the first study specifically conducted to identify knowledge gaps and upskilling opportunities across the national network of AOD helplines relating to methamphetamine and emerging drugs. In doing so, resources and training can be developed specific to the needs of this workforce. From this survey, we identified 3 key training and resource needs. 1, practical community-informed population-relevant information for culturally and linguistically diverse populations and Aboriginal and Torres Strait Islander peoples for calls relating to methamphetamine and emerging drugs of concern. 2, training and resources with a particular focus on families and friends of people who use methamphetamine and emerging drugs. And 3, readily accessible, up-to-date information on new and emerging drugs and treatment of related disorders. This training needs analysis provides a structured approach to supporting the first-line alcohol and other drug counsellors to provide up-to-date and accurate information to assist Australians seeking information, support and advice. Our next step will be to engage with partners in the AOD sector to translate the results of this study into accessible and useful products to support this frontline AOD workforce. I'd really like to thank all the staff who participated in this survey. Thank you.
Thank you. Is Florence still available?
I am, yep.
Oh, great. It's great that you've... Are there any questions? No? All right. Thank you so much for that, Florence. It was great to hear from you.
Thanks for having me.
Your patience. Sorry, we're running a little bit late today. I think that's it for this session. I won't keep you from this afternoon coffee any longer, but we'll be back in about 20 minutes, and I think that's it. Thank you.